This is our Geriatrics Group 2 Depression in the Elderly presentation. Our group consists of Lainey Hybrader, Savannah Hoskins, Maggie Pemberton, and Shaylee Thomas. Our first slide is depression in the elderly. So despite controversy, the elderly population experiences depression and anxiety just as much as our younger populations do, if not more. Depression in the elderly can sometimes be overlooked for a variety of reasons. Some of these reasons being that the elderly may think depression is a result of some sort of underlying condition. So as people get older, they tend to have more health problems. Some of these health problems, such as delirium, can cause depression-like symptoms due to this effect that it has on the central nervous system. Healthcare providers may label depression as a side effect from medication and not take it seriously. Many medications, such as SSRIs, which we will be talked about later more in this presentation by Savannah, can cause depression and feelings of loneliness. Healthcare providers may look at the MAR, for a patient and say, hey, this patient is having signs of depression since they're taking SSRIs. Let's not do anything about it. That should be taken more seriously. Depression can be normalized in the elderly from a prolonged isolation period. So as adults get older, they tend to lose friends and family due to them moving away or simply passing away. So depression can be seen as something normal for older adults due to these losses in later life. However, this also should be taken seriously as it can lead to more life effects later on. A key reason is that the idea of depression is common with aging. So as adults age, they tend to lose their abilities of what they were once able to do, such as play with their grandchildren to be more mobile. So in addition to the lack of mobility, the lack of memory also can play into the stereotypical idea that depression is common in older adults. So the importance of depression. The issue of depression in the elderly is important because it increases the risk of suicide and self-harm in the elderly population. Thoughts of suicide and self-harm are not damaging only to the patient but also their family members as well. This then leads us to our next topic, that not only the elder themselves can be affected by a depression but also their family. This then can lead to a domino effect of depression, suicide, and self-harm. So if one person is down and then other people around them are also around them all the time, they can also become depressed and then lead that same lifestyle that the original person had. Some statistics to back these up come from a study in 2024. This study showed that 19.2% of the global elderly population showed signs of depression. In addition to that statistic, higher numbers of depression in the elderly have been reported in nursing homes. So this means that nursing homes are a key feature in our depression statistic in the elderly, and critical steps need to be taken to turn the statistic around. So when in a nursing home, the nurses can implement activities that the elders can do, as well as bring in their family and their friends to enjoy those activities with them to decrease our depression rates. The elderly population is also more at risk for a suicide attempt if they have little to no social support. This was backed up by a study done in 2022. And being lonely is a scary part about getting older, and loneliness contributes to a lot of depression and suicidal thoughts as aging happens. So it's important to keep up on our social activities. Our main ideas for this presentation include the risk factors for depression, what puts the elderly more at risk, signs and symptoms of depression, what telltale signs show that depression is more prominent in the older adult, and then screenings of depression. Is there any specific tests that could be done to diagnose depression? And then management of depression. How manageable is this depression, and what are some of those interventions that can be done? So moving on into our risk factors for elderly depression, our following risk factors were found with a participation population of more than 1 million elderly adults. So the use of aspirin. The use of aspirin is common in the older adult population, and aspirin can suppress the central nervous system, which then leads to depression signs and symptoms. Aspirin also has some effect on the serotonin receptors, which can then have an impact on the mood. Vision and hearing loss. As people get older, hearing and vision tend to deteriorate. When this happens, sounds don't sound how they used to, and sights don't also look how they used to, which then leads to depression because the adults are then losing their senses, which then depress them. Persistent sleep disorders are disturbances as well. Older adults have a harder time sleeping, and that's also a proven statistic. However, these adults find it harder to fall asleep, harder to stay asleep, and then they also sometimes wake up earlier due to their rhythm just being like that. This can then lead the body to be sleep deprived, and then they can have depression symptoms. Cardiovascular disease. Cardiovascular disease can contribute to depression because this is a very hard diagnosis to hear for some people. Hearing that your heart and your blood vessels don't work as well as they used to can really just put a damper on things in your life. This then can have older adults bottle up their emotions and not want to express themselves, which then would lead to depression. So, what can nurses do for risk factors? Nurses can be a positive light and shed some of that on their depression. Nurses can suggest to the provider to switch to an alternative of aspirin to such as something like ibuprofen. However, this has to be taken into consideration their past. So if they have GERD, this cannot be used. If they have more GI bleeding, this also cannot be used. However, there's also other alternatives out there that can be used in addition, or I should say, without aspirin. We also can encourage vision and hearing screenings, and also the use of a possible hearing or vision aid. So we can comfort the elder in knowing that these are some expected things as you get older, and lots of older adults use hearing and vision aids. Eye and hearing screening should happen every 2 years unless there's an underlying problem, and then that should be happening annually. We also should educate on sleep importance and how to establish a sleep routine. So this means going to bed at the same time every night, waking up at the same time every day, avoiding caffeine before you go to bed, exercising daily to get some of that energy out, and as well as only laying in bed whenever it's time to go to sleep. The encouragement of screenings of cardiovascular disease is also important, as well as the other screenings like mammograms and colonoscopies. A cardiovascular disease screening includes a variety of tests such as blood pressure screening and then abdominal aortic aneurysm ultrasounds and many others. This should be determined by your provider, so talk to them about that. Mammograms should happen every 2 years, and then also colonoscopy should happen every 10 years unless, once again, there's some underlying disorder. And then lastly, encouraging healthy habits like exercising daily and eating healthy based on the MyPlate meal plan can also lower the risk factors for depression. Exercising does not have to be going out running 3 miles, doing a HIIT class, Pilates. It can be lightweight, such as a light walk with light weights.
Okay, continuing on, our second theme is recognizing the signs and symptoms of depression in the elderly. If any of these signs and symptoms are observed, it would be a good idea to have the older adult reach out for help or possibly have a screening for depression. Some of these signs and symptoms can include somatic pain complaints, withdrawal and isolation, whether that be from family members or treatment, appetite changes and weight loss. These can be hard to detect in older adults, but we definitely need to keep an eye out. Prolonged fatigue and persistent sadness. The Geriatric Depression Scale is a tool that can be used by the older adult themselves, family members or loved ones, or even at appointments. It's not a diagnostic tool, but more of a helper to identify the need for further evaluation. Using the Geriatric Depression Scale at routine appointments and providing education about the signs and symptoms of depression significantly lowered rates of depression and led to an increase in early detection. And then here we have an example of a geriatric depression scale and our source listed below. And our third theme is managing depression of the elderly. These are just some options that can be considered when treatment is needed. So we have therapy as one of the options. This could include counseling, hypnotherapy, yoga, and there's many more. Lifestyle changes can include getting more exercise and even going to social gatherings when maybe the older adult wouldn't typically try to go to those things. We have selective serotonin reuptake inhibitors, these SSRIs. These could be like fluoxetine or sertraline. Definitely an option if medication is going to be involved with the treatment. And we have serotonin, norepinephrine reuptake inhibitors, these SNRIs, and this can include duloxetine and venlafaxine, another option for medication management of elderly depression. And as nurses, these are some actions we can take to do our part in managing depression of the elderly. So these implications can include educating them about lifestyle modifications, whether that be some we listed above, like changing up their exercise routine or maybe adding in a medication. Giving resources that the patient can use for help, such as social services. There's lots of resources out there for managing depression. Pamphlets on yoga or body-mind building classes are an option to give them. Encouraging outings with loved ones or doing an activity that the patient enjoys, whether that be you doing it with them or them going out and getting out with their loved ones to kind of make them feel a sense of normalcy. Educating them about adverse effects of medications, especially the SSRIs or SNRIs, as they do have adverse effects, but sometimes the need for the medication outweighs the adverse effects, but we should still educate them on what could possibly happen with the use of those. Setting up follow-up appointments to make sure the patient is on track is very important, because the older adult, we need to keep up with them and make sure that our implications are working. Alrighty, and when evaluating our evidence, we found screening and using the collaborative care model to significantly improve the diagnosing and treatment of depression in older adults. So for our screenings, according to the U.S. Preventative Services Task Force, all adults, including those 65 and older, should be screened for depression in primary care settings. Nurses should normalize using the Geriatric Depression Scale at initial vital checks to ensure early identification. And with improving outcomes with collaborative care, the collaborative care model, the nurses can act as care managers within the primary care team using this model. Using the collaborative care model leads to significant improvement of depressive symptoms and sustained remission. And then there's our source there at the bottom. We also found information from the U.S. Preventative Services Task Force. Okay. And many adults, older adults, already have an extensive medication regimen. So the finding of cognitive behavioral therapy and exercises to be proven to work for treating depression was a significant finding, because older adults can be on a lot of medications, adding in SSRIs, SNRIs could possibly interact with their other medications or just lead to an overwhelming number of medications, so we like to try other things. These non-pharmacological interventions that are proven to work: cognitive behavior therapy, exercise, and problem-solving therapy have shown that they significantly improve depressive symptoms in the elderly population. Nurse-led cognitive behavioral therapy-based counseling and encouragement to exercise improves their physical and mental function of the older adult. And then there's our source.
So after evaluating the issue and evidence presented, we picked 3 changes that need to be made. So this includes increase the use of non-pharmacological interventions. We're going to do mandatory screenings as well, and then we're going to collaborate with members of the care team. So the way that we can bridge this gap, right? So we're focusing on bridging the gap in depression in older adults, and so first we can empower them through educational services, which is vital. So like by informing them of lifestyle modifications and potential adverse effects of SNRIs or SSRIs, then we can foster a really proactive approach to mental health. Second, providing resources and encouraging that social engagement are very key. So like highlighting the importance of outlining the relationships with loved ones and activities that they genuinely care and enjoy. That's something that boosts their mental and cognitive moods significantly. And then alongside this, we can offer them pamphlets or like services that have to do with like mind and body connection, such as like yoga is great for them, anything that's great for mental and physical well-being. Lastly, we want to emphasize the necessity of going to those follow-up care appointments. These are very crucial for monitoring processes and ensuring continuity of care. And we want to reassure this is an urgent matter and very encouraged through their whole life. So by addressing these barriers through nursing interventions, we can dramatically improve the quality of life and care for our patients. Now we're going to talk about a little bit of the nurse's view. So as nurses, we know we spend the most time with our patients, assessing their cognitive function, physical attributes, and so much more. And so we must do an in-depth, comprehensive assessment. So we're looking for atypical symptoms that progress with depression or decipher depression from any mental or physical illness, because depression is often underlooked in our geriatric patients. And so honestly, this is because of lack of expression in our geriatric patients and like the typical symptoms of depression that we see in younger adults and children. And so it's very important for us to screen or advocate for them to get screened for these, less obvious symptoms, such as like poor appetite, lack of mobility, maybe not so good relationships with family members that they had previously talked about, exercise, withdrawal from social events, so on and so forth. And so therapy services should be implemented all around in all kinds of nursing homes and elderly services. And studies have supported this with the yoga and meditation, kind of like what we talked about earlier, over the years to reduce depression. We're going to start with our ethical concerns here, our ethical and legal concerns. And so we're going to start with informed consent and decision-making capacity. So we're determining whether the patient can consent or refuse for themselves. Mandatory reporting versus privacy. So nurses have the legal obligation to report any suicidal ideation. And then lastly, polypharmacy management. So like safe administration and monitoring of medication to uphold that malfeasance. So following up on this, we're going to start with that informed consent decision-making capacity. So depression can accompany other health concerns that may affect those of their mental status, and which then makes us question whether or not the patient can give that safe consent. With mandatory reporting and privacy, there's many controversies that arise with HIPAA and telling a situation to others that may bring harm to the older adult or others around them, so we want to be cautious of that. And then lastly, we've got that polypharmacy management. So because older adults have that slower metabolism as well as an increased number of likelihood of more medications that they're on now that they are older, this can lead to that polypharmacy. And so polypharmacy can cause many adverse effects with our older adult that we want to keep at a minimum if possible. Thanks.
Continuing with our ethical and legal concerns, we also want to present some changes we would make in the nursing practice. All of the following changes are from our Geriatrics nursing textbook by Touchy and Jett from 2018. So we have three main ethical and legal concerns that we presented earlier in our PowerPoint. The first being informed consent and decision-making capacity. We have two solutions we would like to try out in nursing practice. The first being implementing standardized cognitive and capacity assessments. We would also like to develop consent protocols that involve multiple members of the healthcare team to verify ethical consent This allows us to have multiple team members make safety checks for this patient's ethical consent throughout the process. Our next concern is mandatory reporting versus privacy, and our solutions include incorporating an ethics consultation into practice for nurses questioning complex cases to avoid breaching confidentiality. This will also help nurses be able to make difficult decisions regarding their patient safety while having a group to support them and talk them through that decision. We also want to increase collaboration with social services to have coordinated interventions and help for our patients. And then our final ethical and legal concern is polypharmacy management. Our solutions for that include incorporating a nurse-led medication reconciliation to prevent duplicate or contraindicated medications that could possibly have adverse reactions for our patients. We also want to implement nurse education to patients, but also to their families about safe administration, medication adherence, and symptom awareness. These changes we've presented for our ethical and legal concerns have barriers when it comes to implementing them in practice. So our barriers include, firstly, for our informed consent and decision-making capacity. Those barriers are time restrictions, heavy workload for nurses, and difficult coordinations in our overall healthcare team, especially when they have multiple patients, are all over the hospital, and are hard to get in touch with. For mandatory reporting versus privacy, our barriers include limited access to ethical committees, especially because a lot of ethical committees are made up of nurses that have other jobs and roles in the hospital, and errors involving social services. For our polypharmacy management concern, some barriers include incomplete or outdated medical records and low health literacy in our older adult population. So we do have some original thoughts for our ideas involving our ethical and legal concerns. Firstly, nurses are the advocate for the patient's autonomy, their informed consent, and protecting their rights. Making sure the patient knows the risk and the benefits of their healthcare experience is crucial, especially because as nurses, we like to include our patients into their care to promote healing as best as we can. It is also crucial to promote the patient's well-being if they have been diagnosed with depression or if they are showing symptoms of depression. Giving the patient the tools that they need to be successful, such as social services or even a few just simple resources, is extremely important for the outcome of that patient. Going along with polypharmacy, it can be a major issue in the older adult population, so it's critical for nurses to focus on safety, communication, and education for these patients. It's also important for the patient's safety, but also to reduce malpractice involving nurses. We also have some key points in leading geriatric patients to a healthier lifestyle. Our two ideas here, firstly, encouragement. We want to state that change can happen for our patients regardless of their age. Even if they are a member of the geriatric patient population, change can still happen. We also want to address that depression can be temporary and it doesn't have to take over your life if you don't want it to. That's why we share our resources with our patients so they can have ways to combat this illness they're facing. Moving on to validation, we want to ensure the client that their feelings are valid, that we are here to listen to them, and that we are understanding them to the best of our abilities. We also want to remember that generational trauma can play into depression and how the older adult presents themselves. We want to show our patients that this is a safe space to be themselves, share their thoughts, and be vulnerable about what they're going through. Now we have our summary. This encompasses our entire presentation, and we have 3 main points here we want to address. Firstly, that screening in older adults should be of high importance and should be encouraged, especially for doctors and nurses that patients see very often, like their primary care physician. We also want to say that depression very easily can go unnoticed in all populations, but especially in that elderly population. These patients should be evaluated closely by their healthcare providers to decrease suicide outcomes. And finally, us as nurses should encourage therapeutic communication between us and our patients. We also want to provide services to our patients for non-pharmacological interventions such as yoga, music, anything we can do to reduce these depression signs in our older adults. And also we want to promote any advice that our doctor is giving to our patients, such as medication adherence. That concludes our presentation, and we also have listed out our references that we used throughout this presentation. Thank you.